We're excited to be really jump-starting the morning and being your first panel of the day. Yesterday was really interesting the way we workshopped the ideas, and I think that's going to be really insightful this morning, especially on this panel. So let's get started. We're gonna go down the line here and let's do self-introductions. Alan Fairbanks, why don't you kick us off with a quick self-intro?
Well, I'm Coach Al. So I've been in senior living now for about 35 years now. As painful as it was for me to talk about, Chris being 3 decades, I'm about 3.5 decades. So I started in skilled nursing, spent about 5 years there. The past 30 years I've been with Bickford Senior Living, 50 communities, AL memory care throughout 7 states in the Midwest. Spent a lot of time also now with Servium. Servium is a platform that helps operators create revenue streams in areas of pharmacy and hospice and also a lab. We also have a contact center. So those are all things that I'm currently working on as well, is working with Servium in those areas.
Thank you, Alan. Dr. Kathleen Weisberg.
Hi, I think I get the easy job because Trent, wherever he went, he already introduced our company. So I'm Kathleen Weisberg. I'm the National Director of Education with Select Rehabilitation. I am a therapist by background, and I've been working in this industry now 35 years, which is still a little shocking to me that I'm that old. Maybe I'm not that, who knows. But my background has been in neurology. I am a Montessori certified therapist, dementia care specialist certified in fall prevention. I could go on, I'm not going to, but happy to be on this panel to talk about the role of therapy in valuable care, not value-based care, and to be joined by my colleagues up here.
Hi, everybody. Good morning. My name is Frankie Elliott. I'm a co-founder and chief strategy officer of a company called Bloom Healthcare. We're a home-based primary care and hospice service provider. We care for an elderly, medically complex population, about 70% of which live in senior living. 30% live in their private home. And we do that, about 50% of our patients are either in a full risk or shared risk environment. And the other 50% are in fee-for-service. My history with physical therapy professionally is I worked for Kindred Healthcare for 6 years, and we owned and operated, at the time, I think the largest contract therapy business in the United States, Rehab Care. And then for 4 years, I was on the board of directors for a private equity-backed clinic-based physical therapy company. So I've seen the benefits of therapy from many different angles, including being a patient and benefiting from physical therapy myself.
Great. Thank you for those intros from our panelists. So let's kind of jump into it. Everyone in this room is on a different journey on value-based care. Some of you are very experienced with it. Some of you are just starting, trying to learn the terms. And we hope some of our dialogue today in this panel helps those of you that are trying to kind of pick up terms like total cost of care. We hope this kind of helps you in that understanding. But value-based care really is a win-win when there's alignment. Alignment of your operator, alignment with your payer, alignment with your service provider, your ancillary service provider. In this case, this morning, we're talking about rehab therapy. And alignment is a win, and alignment really works when you focus on outcomes. And outcomes is a big part, obviously, of value-based care. Sometimes I think there might be a perception out there that outcomes are maybe it's about utilization with therapy, but it's really about outcomes, because at the end of the day, therapy is to produce, is to get to a goal for a patient. But let's focus on outcomes. Alan, since you're kind of the operator here, talk to us about what outcomes matter to you. We hear about rehospitalizations or hospitalizations. We know that's an important one. What is important to you in your operations?
Well, look, at the end of the day, it really is about trying to get a better, more broad-based view of the overall wellness of a resident, right? So that's what we're really trying to, connect the dots and focus on, is almost like a wellness quotient, right? How actually well are our residents that are in our communities, right? And there's multiple factors. I know this is, we're talking about rehab here, and that's really a big component of it as well. But, wellness is, you've got depression issues, you've got loneliness issues, you've got nutrition, all of these different factors that are impacting how well resident is doing. That's what we're trying to really get a better view of, is how well is the residents in our community. And, rehab plays a very important part in that. And when we think about rehab, it's about how, not just the reactive aspect of it, but it's the proactive, the preventive, right? Let's not just wait until they decline and all of a sudden rush in with some rehab. Let's figure out how they are when they come in, when they move in, what's their functional ability and capacity at that point in time. And let's, at a minimum, keep them there, right? If not, improve them. And that's what we're all about, as that sort of thing. But we're looking at it from the idea of, what is that total wellness of a resident?
I think you just teed up Kathleen. I can see her smiling. Talk to us, Kathleen, a little bit about, you're a therapist, and I meant to say at the beginning, I am not a clinician. I'm a lobbyist, public policy person. So tell us, from a clinician point of view, rehab therapist point of view, what outcomes can y'all achieve? What's therapy's kind of sweet spot?
So I love that, Coach. I'm going to have to just call you Coach now. You mentioned being proactive. I think that's so important. And we mentioned it yesterday, it took us, an hour and a half to use the term AI. But AI is our friend in this case, where we can use technology to be proactive, to determine who is at greatest risk for falls. And when we look at that AI, what that data generates, we're looking at, what is their step length? And I'm being a clinician now. What's their stride? What's their base of support, et cetera? All of those things that are very predictive of falls. So we're being proactive, but we're also measuring those items. So I think that's a big part of it. Excuse me. The other thing, when I think of outcomes and metrics, I could go into a whole host of standardized assessments that we use to show, balance and gait and, ADL and IADL and all of that. For me, take it for what it's worth. I drill it down to 3 simple questions. Did you like it? Do you want to do it again? And do you feel like you got a benefit? And I ask that whether I'm using, a virtual reality headset or if I'm doing a therapy session. I don't think it matters. I ask these questions, simple, because then I can use that information to change my plan of care, to change what I'm doing to benefit that person, to make it very person-centered. So from an outcome perspective, you can go across the boards, but what we are collecting by and large is just what you're talking about. The wellness side of it, the functional side of it. The goal being to keep that person where they are and thriving where they are. I think that's the important piece there. So, it's not just dressing, grooming, bathing. It's, can they make a sandwich? Can they take their medication? So really tracking all of that from a functional perspective.
A lot of that sounds like we want to keep them as independent as possible, in the lowest acuity basis as possible. But we want to measure that too, in order to explain what outcomes that we're able to achieve. What about metrics? Who can talk to us? Talk to me. What panelists wants to talk a little bit about metrics that might be used to kind of measure what's going on? Anybody want to mention that one?
I'm happy to jump in. You want to jump in first?
Go for it. Go ahead.
From our perspective, the metrics are that independence, that level of independence. So where are they on all of their ADL scores using some finite measurement system? And I think the other big metric that we are looking at is falls. I was speaking with somebody yesterday, and that is one of the number one reasons why folks go to the hospital. So I think those are 2 of the big things that we are measuring. And again, it sounds kind of simple, but looking at, transfers and ADL, et cetera.
I think in the broader context of value-based care, ultimately what it boils, there's a variety of metrics. I think there's a lot of them in the back of your workbooks today. But at the end of the day, you're trying to improve quality of care and outcomes at an equal or lower cost. And so everybody plays a part. And playing on the baseball theme here today, a good baseball team cannot field 9 first basemen. And so everybody has a position to play, and it's an important position to play, whether it's therapy, home health, primary care specialist. And I think the key is really around alignment and making sure that everybody is executing in the same play. And so as we think about high value therapy partners, think about, is the therapist working sort of hand in glove with the primary care physician around patient screening and selection? Is there goal concordant care that fits within the overall core care plan for the patient? Are they achieving sustainable functional outcomes without, perpetual therapy? Or if they're plateauing, are we modifying therapy, et cetera? And using industry metrics like the AMPAC deltas to measure functional improvement and adjust from there, et cetera. And so to me, that level of coordination, whether it's really with any other healthcare provider that we're working with in the context of our ACO or any of our other Medicare Advantage arrangements, making sure that there is that level of what I call hand-in-glove coordination and not care fragmentation.
Hey, real quick, I wanted to jump in here. We've got a couple questions that have been coming in from the Slido, and I think one of the elephants in the room here is utilization management, and the idea that you only get so many dollars and value when you're at risk, and they have to be distributed appropriately. So there's a healthy tension that exists between using services in the best way possible to drive the outcomes that you all just discussed, but ensuring that you're doing so in an economically viable and sustainable way so that everyone has the opportunity to participate in that value creation. So I think it would be interesting, just based off some of these questions, Frankie and Kathleen, perhaps if you all could kind of explain from each of your perspectives, Kathleen, what you all are doing to try to partner more on value-based care. Frankie, how you all look to service providers like rehab and others to help you get ahead of that preventative care and proactive care to help to drive these savings and better experiences for the residents. And then, Alan, from your perspective, operators are sometimes stuck in the middle. Your therapy providers are there in the community. People know them, they love them, but then you've got, this person who's saying, hey, we got to really watch utilization. So I'd love to just understand how the healthy tension works there from your point of view too.
Yeah, I mean, that's one of the things that, we talked a lot about in the prep for this panel. And what Joelle's referring to is, if you operators in the room are in an ACO like arrangement with a physician practice group, what's going to happen, and it happens to me every quarter, right? You're going to have your physician practice group start talking to you about therapy utilization and what it's doing to your opportunity to get shared savings, right? And then we as an operator are going to push back and say, well, wait a minute, what about the overall wellness of this individual, and they really need therapy? So we truly are caught right in the middle of that, playing both sides of it. We got a rehab provider telling us, hey, we need more utilization. We got to have utilization. And then we've got the physician practice group saying, you got to cut down on therapy, man. You're really killing us on the ACO side. And really, what Frankie started to allude to, there's this kind of silo that it can begin to exist, but beyond that, it's because there's not an alignment of interest. You've got a fee-for-service situation with therapy that is getting paid on a fee-for-service basis, and then you've got a value-based care arrangement that's getting paid for a total cost of care. So they're automatically out of the gate. There's a misalignment that's taking place. One of the ways we're trying to resolve that in our communities is to really get therapy in the primary care really closely tied, talking in meetings, talking about at-risk residents, what's really happening. Let's look at the total picture of what's going on here. So we're trying to break down those walls of communication to get more alignment, even though by definition, I think there is misalignment because the way you guys are getting paid at the end of the day.
Yeah, I think there is a good point around the alignment. I mean, we've been in the ACO program for 4 years now, and I don't think we've gone to any AL operators and asked them to reduce their therapy. Therapy is a low-cost, high-value solution. We work with therapists every day in the communities. They participate in our resident care reviews. I think there's the alignment and coordination around the delivery of service, and then Alan raises a really good point around the financial alignment, and that certainly is a component of these accountable care models, whether they're total cost of care, shared savings, et cetera. And there are different ways to kind of skin that cat. I mean, I go back far enough, remember the days in different HMO environments where certain therapy providers, and not just therapy, but other types of services, might also share in the risk, so they take a cap for their services. So when we get a PMPM, a total cost of care PMPM for a Medicare beneficiary in a senior living community, we can break that PMPM down for every type of service that's covered by Medicare Part A and Part B, and in the ACO, Part D is not included, but in Medicare Advantage it is. And so we can see based on utilization, what the utilization rate is for every service, what the total cost is for that service, et cetera. And you can begin to align incentives. I think in today's environment, that's a lot less common around taking kind of subcap arrangements. Those are fairly sophisticated. What we have done in our ACO with other types of supportive providers, our population uses a lot of home health. We entered into preferred provider relationships with certain home health agencies, and we were fairly selective about which ones that we chose. And we began to incentivize certain process measures that we believe would lead to the right outcome measures. And a lot of it had to do with things I mentioned earlier, like, are you coordinating with us? In some cases, depending on the opportunity they wanted around the reimbursement methodology, they would discount their fee-for-service rate. They had an opportunity based on their performance to earn that discount back, and then they also had an opportunity to earn a premium to their fee-for-service payment on top of that discount if they met certain performance measures. And those performance measures are obviously mutually agreed upon and are designed to, if I do these processes enough times, I believe we're going to get the right outcomes. And if you put those types of arrangements in place and you succeed in those arrangements, it's a stepwise approach. Then you can graduate maybe to more outcome measures, or then maybe you feel more comfortable graduating to more financially aligned reimbursement methodologies. And that's a bit about how we think about working with those organizations.
That's really interesting. In fact, I think that's our first model, right?
Yeah. Cynthia, can I
And that's a
chime in?
daring one. Yeah, go right ahead.
Joelle told me to say that.
I think you're hearing a theme here, though, as we're talking about this, and every one of you is going to be, as Cynthia said, you're somewhere on this path, and some of you are in relationships with your therapy providers where it is a fee-for-service arrangement. Other cases, that therapy provider is there on an outpatient basis. In some cases, they're home health. I think we've found a lot of success being a dedicated team, because if you're listening to everything that's being discussed up here, it is care coordination, it's communication, it's partnership, it's alignment. And when you have, forgive the way I'm going to say it, a drive-by therapy team, if it's not dedicated, then you don't have that. You need those folks attending your meetings, talking to your physician practices, and not just saying, hey, I want to treat so-and-so, but the why behind the therapy, and that communication, that discussion, that collaboration, it makes all the difference in the world, because at the end of the day, it's for that person. And you made the comment, I mean, a case of therapy is, I don't know, a couple $1,000 versus, I don't know what Trent gave a statistic, $207,000 for a hospitalization. Therapy is a lot cheaper than that hospitalization or that surgery, but it has to be for the right reasons, and that all comes from that communication and coordination that I think you're hearing from all of us.
Yeah, maybe I could, from my perspective, break down kind of what a good relationship looks like and what the opposite looks like. And on occasion, as an executive in our company, I will round with our primary care providers as they're out doing their patient visits in senior living communities and sometimes in private homes. And I recall one instance where we walked into a community and our provider saw their patients for the day, and then there was a therapy provider in the building that was kind of chasing her down and saying, hey, I've got all these patients that I want to start therapy. I need you to sign these orders. And there was never really any consultation around screening and appropriateness and care planning and how does it fit within the overall care plan for the patient. And in another community, you walk in, it's completely the opposite. You're sitting down with a therapist, you're reviewing cases, you're building consensus around what's appropriate before you're communicating with community and family, et cetera. You're building that alignment so that you're not setting someone up potentially for a disappointment or looking like a fall guy, et cetera. And those are the kind of relationships that you really want, is that heavy coordination.
And for the operators in the room, my belief is you need to take the lead in that conversation. You are the ones that need to bring the primary care to the table, bring rehab to the table, and talk about what you want to see from an operator's lens taking place in your community. How are you going to ensure that we put the resident right at the center of every decision that we're making and get rehab at the table, get primary care to the table, and let's talk about how are we going to work together in this community to make sure that our residents get the optimum level of support and wellness that we possibly can.
Hey, Coach Al, can I add to that, man?
Yeah.
Me and you, what I remember is when we first started this value-based care journey together, and we were our infants in this journey, therapy partner was one of our first avenues into that, where we really started to see the value of healthcare in our communities. And that was a tremendous time, I think, in our company's history, is when we really brought in therapy and integrated with them. And we got so excited about it. We were like Oprah Winfrey on a show, but like, you get therapy and you get therapy and you get therapy, and everything was a nail. And I was hammering that beat. Because you know what? I loved it. It added so much value, and those therapists became part of our team. They became part of our culture, and it was wonderful. And that was a good season, I think, in our value-based care journey. I think where we're at now is we're just taking that next step in that journey of integrating that therapy partner as part of our community. And once we started getting in those value-based structures and relationships, it's not about more therapy is better. It's the right therapy, and aligned therapy and integrated therapy is better in partnership. And that's just an evolvement, I think, of where we've come, and I think where we all need to head.
We're kind of heading towards it, but Alan, would you talk a little bit about total cost of care? I want to be sure we got a little bit closer there with Frankie, but that's a phrase that folks in this room need to understand. And it's, the right therapy, the right amount of therapy kind of leads into that.
I mean, I can talk about it, but Frankie's the one that's like getting the checks. He's probably more the one to talk. But at the end of the day, it's really like there's a total cost that we pay to care for these residents, right? And when you're thinking about an ACO, there's a dollar amount there, and then you're going to get a potential to get a shared savings piece of that, right? If we do a good job of keeping people out of the hospital, out of the emergency room, and the right utilization of services. And therapy is one of those things that kind of draws down on that total cost of care. So at the end of the day, you may have less going into your pocket because of the utilization of something like therapy. Very, very basic. I don't know, Frankie, you can add to that.
Yeah, I mean, basically in total cost of care models, every healthcare service is a cost, right? Primary care, specialty care, home health, hospitalization, pharmaceuticals, everything's a cost basis. And many of these models are not just shared savings, they're full risk. And we got into the ACO REACH model a few years back, and we went into the global risk track, and we were a small organization, founder funded, and we were taking global risk on a subset of Medicare patients. And in that model, if you exceed the total cost of care budget, the benchmark they call it, so basically there are a number of Medicare patients who are attributed to our physicians and primary care providers in our practice. And Medicare says, okay, going into this year, we have set an actuarial budget for your patients, that their total cost of care for Medicare covered services is going to be X. If you come in under X, well, first thing they do then when they set that budget is they say, we are taking our guaranteed savings as the federal government off the top. So now they've locked in their savings. Now you're getting X minus some percentage, and you manage the patient and their total, all of their services for the year. And at the end of the year, we're going to add up the expenses and we're going to compare it to that budget. And if there are savings, then we're going to distribute those. If there are losses, you owe us a check back. And that was a decision where, principals at the business had to sit around the table and do some math and then swallow hard. And, but made a decision to move forward. We felt like it was the right thing to do. It's the right model of care. And so in that environment, accountability is important. I mean, nobody likes to talk about the money aspect of this business, but it is a reality. And at the end of the day, whatever service we're providing, there's a cost to it, and somebody's bearing that cost. And so as we think about these models and partners, aligning not only around common clinical goals and objectives, but also around that financial accountability is important, because at the end of the day, if we run over, somebody's going to end up writing a check.
Yeah, the money is important. A total agreement there. Just shifting gears just for a second here, Kathleen. People in the audience might be thinking, okay, I want to talk to my rehab therapy company now. What questions should they be asking? Or if they don't have a relationship with a therapy company, what are some of the things they should be thinking about when they want to maybe think about a model with a therapy company or just start a relationship? What kind of questions? What should they be looking for? Number one, what kind of outcomes can that company produce for them? I would imagine.
100% it's outcomes. And as the therapist in the room, I'm going to say to all of the operators in the room, go into your therapy space, ask the questions, observe, what are your outcomes? What are you doing? When we're talking about cost of care, if I really focus on function, what is going to help that person to overcome a barrier, what's going to help them with their wellness, I can do that. Again, we're looking at that partnership there. I think if you're looking at, who am I going to partner with? You want someone who is going to be there day in, day out, coordinating with you, communicating with you, et cetera. And I think also helping you with some of your sticking points. I was talking to somebody yesterday who said, now that we have a physician group with us, the acuity of our folks has increased. We're seeing more wounds. We're seeing more issues with behavioral health. We're seeing more issues with falls. So as we're talking to a therapy provider, I want to know, what can you do to help me? How are you going to align with me in those areas so that I'm going to see the same outcomes? But I think first and foremost, get out there and ask the questions. Ask, what are you doing? How are you doing it? And make sure that they're communicating with you.
Anybody want to add to that?
I would absolutely agree. I mean, at the end of the day, as operators, we need to embrace the healthcare that's taking place in our communities, get involved, and ask questions, and do everything we can to break down the silos that exist in our communities when it comes down to the care that's being provided by all these disparate groups that are coming in, working with our residents at the end of the day. So how do we do that? And to me, it starts with acknowledging the healthcare that's taking place in our communities and understanding and realizing we are providing a heck of a lot of healthcare in our building. And our residents, go sit down and listen to what they're talking. They're talking about health. They're talking about their health at breakfast, at lunch, at dinner. They're talking about their health. They're talking about their loved one's health. They care about that very, very deeply. So we should as well. And we do embrace that and not run from it.
Excellent.
Can I just add in one more thing? And I think it came from the press box where you said that they became your partners. And I think that's the critical piece there too, is that you need to share data with your rehab provider as much as your rehab provider needs to share back with you. If you're going to have aligned goals, whatever it is, we have to talk, we have to share. I think there are still those pockets out there where we say, well, I'm not going to tell you that because you're my vendor. and it's those silos. It's what we're talking about, breaking those down if we're truly going to get to some sort of resident health.
Excellent. Well, I think one more, we're out of time. You want one more comment?
We're at breakout here. So remember, this is the meat, guys. We're at, I don't know what page we're on, but find the right page.
Page 20.
Page 20. Those are the questions. They're a guide. Have a really good, robust conversation. We got 20 minutes. We'll roam. The coaches will roam. And then we're going to come back and we're going to integrate what was talked about at your tables. So have a good conversation. All right. So therapy, rehab. What were some of the things that were heard about? What Andy kind of said, he put himself right in the middle of a little bit of a storm there, maybe. So
Yeah. Hey, Coach Al. Hey, you've said, one thing about Coach Al. You're on the panel here, and so it's good to see you as a panelist here. And one thing we've always taken from you, Coach Al, is you make a lot of comments, kind of the Moneyball approach to baseball, and got to know your data, got to know your information. And one thing about Coach Al, man, he knows all his numbers. He knows all his numbers and all his players and all his data. That's why he's been such a good coach for so many years. And so, Coach Al, I was curious, what was your Part B spin in 2024? What was the exact amount? And how did that compare to previous years? Can you give me the numbers on that, Coach?
Yeah, I can. So last year we spent what?
I know what we spent on therapy last year.
Yeah, there it is. Somebody at risk gets it, right? No, but hey, I came and sat on this table at purpose. I had the opportunity sit here with Jason, therapist from Fox, great relationship that we've had over the years. And then I also got the sit right next to Jason Fierman here, who was on the Hall of Fame panel from the payer and the ACO world. And so I had payer and therapist, and there was an empty seat. So I came sliding right in here. It'll be right in the middle. And super rich conversation, and really, really impactful. And one thing that Jason Fierman here listed is, as he was talking about, and from the mouth of a payer and person who's been very successful over many years, one quote that he said is, "Doesn't matter what the cost of therapy is, as long as you create the outcome." And I thought, and Jason, if you could just unpack that a little bit more for us, that was a really impactful quote for me.
I hope that was enough for you. Yeah. So no, I appreciate it, and I think it really goes back to Frankie led off his comments by saying it's a low cost, high return service, and as you think about therapy and the ability to keep people out of the hospital, that's what all this is about. You're comparing, I don't know, a couple $1,000 therapy session over 12 visits to a $20,000 hospitalization, a $20,000 SNF stay, and the possibility that person doesn't come back to the facility and continues to utilize high-cost services. So I, too, have learned a lot from this discussion, just the value of physical therapy in this environment and the ability to retard or deter future high-cost services that I described.
Great. What else? What else kind of came and bubbled up as you guys were having conversations at your tables when you talked about therapy and leaning into therapy? I think you had a table that talked and really began to think about it a little bit differently. I think you said, Kathleen.
So table 12, I sat in with them just a little bit, and they were thinking differently. They were thinking about, okay, you have this therapy session or this length of care, whatever it is for therapy, but it can't stretch on forever and ever and ever. So what are our options? And they were talking about wellness, and they were talking about, which again taps into what we were talking about up here, and using some external services that maybe can carry that person. I'll use the term restorative, if you will, not exactly that, but it carries that person longer time. And then again, if there's a change, there's a problem, we come back to therapy, but it's a way to leverage a length of stay that maybe is a little bit shorter, but again, is very impactful for that person. So kudos to table 12.
So, Frankie, help me we talked about, hey, therapy's worth it. Keep them out of the hospital. How do you kind of prove that, right? How do you say, hey, it's working? They're out of the hospital. I mean, you're still spending the money, right? So you're like, how do you balance that?
Yeah, it's hard because it's not a direct line. I mean, you have to account for a whole variety of other variables and services patients are receiving, their conditions, et cetera. And I think where we really start is kind of, this was a conversation that came up at a table in the back. Really, to my point earlier, I think if you start with reward the processes that you think credibly believe are going to lead to the right outcomes, then measure those outcomes. And if they're not, then adjust. If they are, then maybe you move towards more, rewarding outcomes, et cetera. But it is at times hard to say, Mrs. Jones didn't have a hospitalization. Is that a product of the therapy they received, the home health services they received, something the senior living's doing, great primary care? The reality is it's all of it. And so it's about coordinating those services, being thoughtful about when is the right time to pull the right levers, whether it's therapy or any other service across the continuum. Unrelated to senior housing, but when I was doing some work with results physiotherapy, this issue around outcomes and how do we tie the work they're doing to outcomes. And they had an issue with one of the largest payers in the market. And we went to that payer and said, look, we think we're delivering better outcomes post-therapy when therapy is over than others in the industry. And so we picked certain conditions where therapy is common, and after like an acute episode or any, maybe it's not acute, maybe it's an outpatient surgery. And they basically leveraged all of their historical claims data for our patients and our competitors' patients. And we said, what is the cost of care for patients who have these conditions, normalizing for risk adjustment and all these other things, at 30, 60, 90, and like 180 days post-therapy? And what they found was that this organization was doing a better job. And so ultimately what they did was they narrowed their network, which is what they also gave us a rate increase, which was nice, but they narrowed the network and they basically said, we want to steer more of our members to a high value. We define that as valuable, and we're going to steer more of our patients to a higher value therapy provider. And so I guess what I would say is I tell that story as you're grappling with how do you connect these dots, is work with organizations who have the data that can help you do that, and see what the data tells. And sometimes it's going to tell a good story, and sometimes it's going to tell a story that there's opportunity. And if there is, then you got to be real about it, and you got to be intentional about going out and capitalizing on that opportunity to get better. Nobody's perfect. Same in our organization.
Yeah, and I think that's, Jim.
Well, I don't want to call on anybody, but Table 7 was concluding with some pretty interesting discussions because, first of all, Part B encapsulates more than physical therapy, to be clear. Sure. Like, Part B is a big category in spend, so it also includes things like labs, it includes things like specialists, injectables, so one quick thing. But in addition, the group over there was talking a lot about question number 3 in the balloon squeeze kind of model. And where they were really also reminding all of us at the table was your Part B therapy suite in your community is just one of various therapeutic options. There are options that also include home health. I heard that. And that's one additional level that a resident may or may not need depending upon their care journey. But they also talked a lot about activities and exercise programs in the community, and even some direct-to-consumer models that are here with us today that some of these residents are taking it upon themselves to sign up for that aren't cost of care at all. So just remember, too, that many of the times our residents are moving into buildings, they might certainly need therapy, but does it always require skilled therapy? Does it always require a physical therapist and a prescription and a care outcome, or should it just be fitness is wellness?
I think it's a really good point. One of the discussions I had at a table over in this side of the room was around total cost of care. And to put total cost of care on the medical side in perspective of senior living organization is For those of you operators in the room, say you're running a 100-unit building and it's full and everybody's paying you $8,000 a month to live in your community. And for that $8,000 a month, you have certain responsibilities and care that you have to deliver. And what if I walked in and said, hey, Miss Jones needs more hours of this, and Mr. Smith needs, more of this, or so-and-so needs less, but I'm not paying the bill, right? Now all of a sudden you're going, wait a second, I have staffed and I've built my care plans around my business model, and if someone's going to come in and start ordering more services, I got to be rethinking my revenue model, my staffing, et cetera. And it's a direct, comparison to total cost of care on the medical side. And so to Jim's point, like there's this total allocation, and you have to achieve, the goal is you're trying to achieve certain outcomes, right? And one of them is, days at home. You want to keep residents in your community and independent and high functioning as long as possible. And you have to pull the various levers that are available to you to achieve that. And ultimately we're trying to do the same thing, and trying to do that. And the way to get there is really through coordination and making sure that right hand knows what the left hand's doing.
I just want to chime in real quick to Jim's point. This is where it goes back to you as the operator knowing the services that are available, and more important, knowing the individuals who live in your communities, because you have all of these services, but you also need to know what is the scope of practice of that service. So if it truly is a skilled need, you don't want to give that to the YMCA, for example. If it is loneliness or social isolation, that's a perfect opportunity for activities or wellness. So it's really knowing what your services are, what they're able to do, and bringing it back to that, and knowing what your residents need.
And it starts with asking the right questions.
Absolutely,
Right?
100%.
I mean, that's where it starts. And again, I put it back to, as an operator, owning what's taking place in your communities. And as
100%.
Jim indicated, as we're all talking about here, right? If this person, it's going to be a challenge for therapy, what are other options that we have? And bring a Frankie and a Kathleen to the table and talk about it. And as an operator, it's incumbent upon us to do that and lead that conversation. Frankie's going to come from one angle, Kathleen from another. We're going to come from another. Let's get in a conversation and put, the resident at the center and have that conversation and get an outcome that we all want at the end of the day.
Thank you, Coach Al, because that's exactly what I was just about to point out as well. Is, in this conversation, we've got our healthcare provider represented on the primary care, maybe risk side. We've got our therapy partner, representing what they think is best for the resident. We have the operator. Coming back to what the resident wants matters tremendously. And I think that I look at the three of you and what you represent on the stage, and I think each of you have a perspective on what that resident wants that, we need to bring to the table. And the truth usually lies somewhere in the middle of the point of view that all of us have. And so how do we continue to partner very effectively and also think to ourselves what's best for the resident, and what we actually think that they want. And then, I think something that operators, I would encourage all of us to be thinking about is, how do we start bringing residents and their families into these conversations more constructively and effectively? Is there an opportunity for us to actually have them be more engaged? I love patient-centered care. I also really love patient-directed care. And so are there opportunities for us to bring them, thank you, Mary, shout out to you, to the table? And Evan, this is tied directly to a lot of the work that you all do as well. So again, I said I was going to be the one bringing the resident back into this conversation, so thank you for hitting on that.